charts based on HbA1c and ACR. First of all, a general review on HbA1c. What is HbA1c? It is a type of hemoglobin, glycated hemoglobin. Glycated means it is a non-enzymatic process. Here, there is an addition of sugar to the hemoglobin, and HbA1c is a blood test parameter which is considered to be the best index for monitoring the long-term control of blood glucose, okay, particularly in a diabetic patient, the established diagnosed cases of diabetes. Usually it is done once in 3 months, okay. Now moreover, it is very much related to the complications. It is a very good predictor of the different complications of diabetes like retinopathy, nephropathy, neuropathy, etc. So it becomes a predictor of progressive renal damage also, and we can keep a track. It's a very important factor by which we can keep a track of the persistent hyperglycemia, thereby leading to chronic complications. What is the reference range units of HbA1c? It is expressed in percentage. Reference range, as you have already learned, I think, in regulation of blood glucose chapter. There are 3 groups. In normal, we are having 4 to 5.6. If it is impaired or intolerance group, then it is 5.7 to 6.4, and 6.5 or more is considered to be diabetic. In fact, was considered to be profound diabetic, according to ADA, WHO, both. But from 2019, ADA, that is the American Diabetic Association, has recommended that 7% or more will now onwards be considered as diabetic. It has raised, and ADA has also recommended this HbA1c to be the preferred method for first diagnosis of diabetes. Okay. Why? Because there is a reason that it has been seen that reduction in even 1% of HbA1c leads to 30% reduction of the chance of long-term complications. Next we go to collection of samples. Where do we collect? In EDTA vials. And there is no such time which is required, like fasting sample is required or postprandial. There is nothing such required. It can be done at any time. This is the most preferred thing. The importance is that many advantages are there. First, as we have already discussed, like any sample can be collected, random sample. Second is that the intra-individual variability is very less. Then the sample is very stable. Like the glucose sample, you cannot keep for long before processing because the sugar level falls down. But in HbA1c, it remains stable. It is not altered by acute factors like fever or some diseases, okay, or by exercise, etc. And it is the better and best index for predicting the complications. Thereby, it has been the preferred method of first diagnosis. Also, indication, what will you say? The indication, you may say that wherever we are having inconclusive fasting or postprandial levels, there we may definitely go for HbA1c in gestational diabetic patients particularly, and definitely, as I mentioned, for the long-term monitoring of blood glucose in established cases of diabetes. The timing of the test, I have already mentioned, there is no particular timing. But definitely, if you are going for the monitoring in diagnosed cases of diabetes, we have to do it at least once in 3 months. But it has been seen, it is related to particularly the RBC lifespan. It gives us an account of last 10 to 12 weeks, okay, not for this very moment, what is the sugar level or what is the hyperglycemia level. It gives us the status of 10 to 12 weeks, last 10 to 12 weeks, okay. And though the RBC lifespan is very much related to it, it is usually 120 days, but it depends on the RBC lifespan, okay. Wherever the RBC lifespan is less decreased, then the HbA1c value also it reduces. So preferably now it has been shifted from 3 months to 2 months. So we do once in 2 months, because consider that 50% of this HbA1c value is dependent on the new red blood cell generated, or the new red blood cells which bind to the sugar, and the other 50% on the previous month. So it is done once in 2 months. Maillard reaction. So this is a reaction which is occurring when the sugar actually binds up with the hemoglobin. It forms what? An aldermin, a Schiff's base, okay, with the N-terminal amino group of proteins. Okay, so what is that sugar? Usually it is glucose. Glucose joins up with the N-terminal amino group of proteins. Okay, thereafter, after forming an aldermin, an amidary rearrangement takes place to form the ketoamines. Okay, so this reaction is Maillard reaction. When once attached, the glucose is usually not removed from the hemoglobin unless and until the RBC dies off. Okay, the HbA1c subtypes. Okay, now HbA1, this is the broad category. Under this we are having HbA1A1, HbA1A2. So what is this difference? Somewhere you are finding C, somewhere you are finding D. What is this? A1 means it is just the difference of the sugar. Okay, when we say it is A1, then it is understood. Now usually see HbA1c is the most common form. There the sugar molecule is definitely glucose. Okay, it's the most common one. It is bound up with the N-terminal valine of beta chain of hemoglobin. When we say A1A1, so it becomes fructose 1,6-bisphosphate. When it is A2, it becomes glucose 6-phosphate. Okay, and here in the fourth one, when it is D, it means the sugar is not changing. Sugar is glucose only. But the connection which you are having in the protein, instead of valine, the amino acid changes to lysine. So lysine residues of alpha or beta chain of the hemoglobin is been joined up here. Methods of estimation of HbA1c. Now, there are different methods like HPLC. HPLC is the high performance liquid chromatography assay. Then we are having antibody based latex enhanced immunoassay. So in our department, this is the preferred method we go for. There are also other methods like enzymatic assay and ion exchange chromatography. Now in HPLC, what is the disadvantage? As it is a column chromatography, the different types of hemoglobin comes together down through the column. So what will happen? There is a misnomer, or the disadvantage is there. What will happen? That since the HbA1c, HbF moves together similarly, so what will happen in case of thalassemia, you will find very high values of the patient of HbA1c even though non-diabetic. Similarly, in sickle cell anemia, you will find the lifespan of RBC is reduced. So the HbA1c values are also very reduced, though the patient may have normal or say high values, but you may find reduced. So these are the disadvantage you may have in HPLC method, though it is preferred in most of the laboratories. Now charts on HbA1c. First question, a 40-year-old woman weighing about 80 kg came to OPD of a hospital, complaining of weakness, lethargy for last 2 to 3 months. She also noticed she felt very thirsty. Okay, this is a polyhydria, you can say. In the night, she gets up 4 to 5 times for urination. Polyuria is there. Okay, polydipsia, polyuria. Okay, and polyhydria is not mentioned. When asked about the family history for such symptoms, she told that her mother had such symptoms for which she had been started with some treatment. Maybe it is some insulin or oral hypoglycemic, whatever, she does not know. On physical examination, she appeared dehydrated with dryness of tongue. She had mild rise of BP. And there was no other findings. Following are the results of investigations done. We are having FBS is 152 milligram per deciliter, PPBS is 246. So you see, fasting blood glucose, if it is more than 126, considered to be diabetic. PPBS more than 200 is considered to be diabetic, and HbA1c, you can see it is 14%, it's much higher. So leading to some complications. Have you seen? So in the RFT and lipid profile parameters, cholesterol is very high. Okay, more than 200. Here it is 270. Urea is okay. Then X-ray and ECG is also normal, they are saying. So in this case, what is your diagnosis? Definitely the person is suffering from diabetes mellitus. It's a type 2 because family history is there. It's a non-insulin dependent and type 2 diabetes mellitus. Due to insulin deficiency, the glucose entry from the blood to cells is reduced, and so there is less metabolism of glucose for energy production. The patient feels lethargic. Frequent urination, because here the threshold for glucose, see, usually it is 180 milligram per deciliter. When it goes beyond this, you will find glycosuria. So polyuria occurs due to osmotic effect of urinary glucose. The patient is having dry skin, sunken eyeballs. This is because of dehydration. Now, what are the investigations you would like to do further? You will see for serum electrolytes. Okay, in a dehydrated patient, you should see for serum electrolytes. Okay. Comment. Now, HbA1c, as we have seen, it's much higher. And it indicates that hyperglycemia has been persisting. Okay, at least you will get a 2 to 3 months picture. So that is all, where we have seen a diabetic patient with appearing with all the complications. A 52-year-old woman with a medical history of hepatitis B, hyperlipidemia, hypertension, anemia presented to the medicine department for a routine visit. Laboratory test 3 months previously had revealed an impaired fasting glucose concentration of 118 milligram per deciliter. Therefore, a hemoglobin HbA1c analysis was performed, and by HbA1c it showed 12.8%. Now see here, anywhere you do not get impaired fasting glucose concentration 118, so it is not in the diabetic range. Okay, and besides this, you don't get anywhere any such sign and symptom or any such blood parameter level which gives you the indication of diabetes, but still then you find that HbA1c is so high. Now this is a clear picture when you have got some hemoglobinopathies. Okay, there may be thalassemia. So in such a case, see, because hepatitis, hyperlipidemia, hypertension, and laboratory tests 3 months previously. So every 3 months, like there is a tendency for the thalassemia patient coming back after every 3 months. Okay, for the test and for infusion, transfusion. So what happens is that in HPLC method, I have already mentioned. So coming through the same column, the hemoglobin F and S, it comes with the hemoglobin A1C. So there is a tendency, so since the hemoglobin F is increased or A2 is increased, you find that HbA1c is also raised. So this is the disadvantage of the HPLC. So in this condition, what you should advise for? Go for hemoglobin F and hemoglobin S. Okay, sickle cell as well as the HbF, the fetal form. So wherever you are finding some altered erythrocyte lifespan and changes, so this is going to bring about a change in the degree of glycation. So HbA1c testing cannot be used for these individuals. Then how do I go for prediction of hyperglycemia, persistent hyperglycemia? In these cases, I have to take the help of some other lab test, which is a fructosamine or glycated albumin. So which is also giving me a picture of the hyperglycemia, but last 2 to 3 weeks. Not as HbA1c, but in these cases of patient, I have to take the help of those tests. ACR, that is albumin creatinine ratio. So what is ACR? It means the patients with diabetes mellitus are at high risk of suffering renal damage. So whenever there is a renal damage, so there may be loss of protein. And when this is compared to the creatinine and we find the ratio, that is the albumin creatinine ratio. End-stage renal disease requiring dialysis or transplantation, it develops in approximately 1/3 of the patients with type 1 diabetes. So we see that the patients which are progressing towards nephropathy, the first and early stage which is being seen is the microalbuminuria. Okay. So early detection of diabetic nephropathy, it basically relies on the test of urinary excretion of albumin. The reference range, what is it, and the units? It will be expressed in two ways. It will be either milligram per gram of creatinine or it may be microgram per milligram of creatinine. If you consider a ratio, you may not have either of the any units. Okay. The normal range is less than 30 to 300, that means up to 30 is normal. Then more than 30 to 299 is considered to be the microalbuminuria range, and more than 300 is your macroalbuminuria range, that is nephrotic syndrome range. The collection of samples, you have to take for microalbuminuria we used to take 24 hours urine sample is the ideal, but for ACR we may also shift on to spot sample, okay, the random sample. So the preservatives is not required, and ACR is more preferred to microalbumin. Can you say why? It is because ACR is more preferred method. It is because of the correction of intra-individual variation in urinary volume. So if the volume changes, it does not remain the same every day. So the creatinine value also changes. So it is more predictive if we can compare the albumin creatinine ratio rather than seeing only the albumin loss. Regarding the causes and pathogenesis, now the presence of increased urinary albumin excretion denotes an increase in the transcapillary escape rate of albumin and therefore is a marker of the microvascular disease. Okay. The persistent urinary albumin excretion greater than 20 microgram per minute, it represents a 20-fold greater risk for the development of clinically overt renal disease in patients with the type 1 and type 2 diabetes. So we have seen that in a diabetic patient with a new onset of diabetes within 5 years, so immediately by 5 years they happen to develop this microalbuminuria, that means loss of albumin excretion. Okay. So when this initially starts, okay, so the renal function, when it starts its deficient function or the renal insufficiency seen for the first time, we should try our best to catch hold of the process at that time itself. Okay, once the nephropathy already develops, though we start the treatment, we can just retard the rate of progression without stopping or reversing the renal damage. So this early stage can be trapped with the help of microalbuminuria. More important is finding out the ACR. So why better than microalbuminuria test? I have already said, because there remains always the problem of intra-individual variation if you consider microalbumin, because the urinary volume doesn't remain the same, and if you consider creatinine along with that, so this error is being corrected. Methods of estimation of ACR. The different methods are immunoturbidimetric method, most preferable and done in a department. There are also other methods like ELISA, radioimmunoassay and radial immunodiffusion method. The indication. So why do we go for ACR? For the diagnosis of nephropathy, okay, whatever nephropathy it is. So firstly for the diagnosis of nephropathy. Then for the detection of early stage of diabetic nephropathy. Okay, whenever we find an increase in GFR, hypertension, microalbuminuria, so for that diagnosis. Finally, we are having prognosis of progressive renal disease. Okay, so that is what? Progressive loss of renal function in renal disease, diabetic nephropathy, chronic glomerulonephritis, reflux nephropathy, whatever it is. Okay, so accordingly we can catch hold of the process, we can go for treatments. Then the PCR in relation to ACR. Now this PCR is not polymerase chain reaction, it is protein creatinine ratio. So why that term has come? It is only because it has been seen over the years that whenever there is loss of protein in diabetic nephropathy or any sorts of nephropathy, we see that there is a loss of ample amount, various types of protein besides albumin. So these days there are recommendations that we should consider for protein creatinine ratio, the different types of proteins which are excreted rather than only albumin. So the different proteins, what are these different proteins besides albumin? Like in multiple myeloma, we are having Benz-Jones protein. Then we are having immunoglobulins, okay, like alpha-1, alpha-2 microglobulin. Then immunoglobulin G. Then KIM is the kidney injury molecule. Another one is NGAL, that is neutrophil, gelatinous, associated lipocalin, etc. So there are various amounts of different types of proteins which are excreted in urine over 24 hours. Now what is the normal, the unit and the range? It is usually, if we consider in milligram per day, that is milligram per gram, then it is gram of creatinine. It should be less than or equal to 150 milligram, okay, per deciliter per day. And if we consider in milligram per millimole, then it becomes less than 15 milligram per millimole. Accordingly, you can see there are various grades, okay. Like if we consider the first unit, that is in milligram per gram of creatinine, we can say less than 150 is normal. Trace proteinuria is 150 to 500 milligram, okay, and significant becomes more than 500 milligram per gram, and nephrotic range is more than or equal to 3500 milligram per gram of creatinine. Similarly, we are having in case of milligram per millimole, less than 15 milligram per millimole is considered to be normal. 15 to 49, it is the trace proteinuria. Then 50 to 99 milligram per millimole is a significant proteinuria. 100 to 300 is high proteinuria, and more than 300 milligram per millimole considered to be nephrotic syndrome or nephrotic range proteinuria. Now PCR is more important, okay, and it is more predictive of the nephropathy as compared to ACR. Now PCR, what are the different methods we go for? First is the immunoturbidometric method. It is the most common method you have seen, okay. Besides this, immunoassay, this is also a preferred method, okay. Among the immunoassay, immunodiffusion immunoassay, electroimmunoassay, light scattering assay with particle enhancement, and labeled immunometric assay, by which the particular proteins like KIM1, as I've mentioned, NGAL, these are being detected. The charts on ACR. The first question is a 54-year-old man, established case of diabetes mellitus and on irregular medication since 7 years. So from the first line itself, we have got an idea, established case of diabetes, and you already know by 5 years only the microalbuminuria, it starts appearing in urine. Now his lab investigation shows as follows: urinary ACR 232 mg per gram of creatinine, urinary sediment bland, total serum protein 4.1, that means it's very less, normal is 6 to 8 gram per deciliter, HbA1C 8.9, it's more, ppbs 550, definitely much more, diabetic range, BUN and BUN and creatinine values 45 and 3.2, so both are really increased. So this gives us a picture of established case of diabetes leading to complications, where the complications has already evolved for nephropathy, yes, chronic renal disease, isn't it? So all the sugar level, HbA1C is higher, protein excessive loss is there, so there is microalbuminuria, and ACR they have provided only, it's much more. Give your interpretation for the patient with the following observations. Blood urea is 80 mg%, creatinine 4 mg%, both are higher. Serum cholesterol 400, even this is higher. Total protein 4.5, protein is very less. Albumin 1.2, even this is less. ACR is 6000. So this has gone to nephrotic range proteinuria. So nephrotic range proteinuria, I said if it is more than 300. Okay, so if it is more than 300 we consider, okay, then it becomes nephrotic range. 300 to 3000. Please go through the charts. These are very important for you as well as the topic. And if there is any problem, please let us know. Thank you.